things. Some of you may remember back in 2001, there was a Minnesota Vikings football player named Corey Stringer who died of heat stroke. And there was a lawsuit following that, which his family won. And after that lawsuit filing, they started the Corey Stringer Institute, which Dr. Casa heads up. He was an expert witness in that case on heat stroke. And after hearing him speak, I realized that the protocol that we currently had for heat stroke, which was basically move the patient to a cool environment, place heat packs under the armpits, the neck, the groin, that thing, and it really was going to kill people. We needed to change what our treatment was. So when I came back from that conference, I spoke to my partner at work, and we met with our medical director, and I eventually got the protocol changed for the state of Michigan as far as the treatment of heat stroke. And there's really not a lot of things in medicine that will kill you quickly, but heat stroke is one of them, and it's 100% preventable. So that's why we really want to get the information out as to why it's so important for us to treat these patients quickly. So just a few statistics for you as to the prevalence of heat stroke and why it's so important. In the last decade, the U.S. averaged over 600 heat-related deaths per year, and it's the leading cause of morbidity and mortality in our high school athletes. If you look back to the creation of the NCAA, it was really one of the reasons why the NCAA was founded. Back in the days of Teddy Roosevelt, we were having a lot of college athletes die. Some of it was due to fights, but a lot of it was also due to heat stroke. And he basically said, you know, if we don't stop killing our college athletes, I'm going to suspend all the athletics. And so that was kind of how the NCAA came about, and they really did a decent job of putting guidelines out there so that we didn't have these heat stroke fatalities. A few years back, I had an opportunity to meet with a number of athletic trainers in the area, and they told us they actually would not call EMS until they had the patient cooled down to about 102 degrees, because they were concerned that we would stop the treatment and push to transport rather than treating them on scene like we really need to be doing. And we'll talk a little bit about what that treatment is. But it is 100% preventable, and that's why it's so important for us to take care of things right away. So let's look at a little case study here. This looks at Chicago and the heat wave that they had in 1995 and then again in 2012. And if you look at the differences in deaths, they're extremely different. We have 739 deaths in 95 versus the 18 deaths in 2012. And the chart on the bottom left shows you what the average temperatures were. And if you look, they're very similar. Really hardly any difference at all in what the temperatures were. But if you look at the chart on the lower right, you'll see the heat index. And it's extremely different there. So the heat index factors both the temperature and the humidity. And there's significantly more time in that high heat index area in 1995 versus 2012. So why is that so significant? Why do we need to know about that? If you look at the way that we lose heat, I have the first one listed as evaporation. And the reason I have that listed as the first one is because on a day-to-day basis, as our bodies are trying to maintain that 98.6 degrees, the main way that it cools is through evaporation, through sweating. And so if the humidity is too high, it doesn't accept that extra moisture. And that's why we feel sticky in a humid environment. And that's why everyone says, well, it's a dry heat. That's better because it's a dry heat. And there really is some truth to that, because in the dry heat, we still have that ability to sweat and to evaporate that sweat. The next way that we cool ourselves on a day-to-day basis is through radiation. And basically what we do there is we radiate our heat into a cooler atmosphere. So right now, as we sit here, we're radiating it out into our homes or out into our ambulances. Next is going to be conduction, and basically that's us touching another cooler object, and conduction is going to be a key part into the active cooling that we're going to do for the heat stroke patients, and we'll talk about that more in a little bit here. And then convection is going to be wind or water moving by us, which is also important in us cooling our patients. So how do we defend against heat? Well, through the ways that we just talked about, but then also through vasodilatation. If you have been into the heat or into the hot shower, you may have noticed that your veins look really large, and that's because your body is trying to get that blood out to the surface so that it can be cooled. So that's really important for us. Core shell shunt, meaning we take that body from the core and we try to push it out to the periphery so that it's able to get cooled. Sweating, like we talked about, and then we also increase our respirations and we increase our heart rate. So keeping these things in mind, it's important to understand our patient's medical history and also any medications that they may be on, because certain medications will affect a patient's ability to do this. Heat shock proteins is something that is kind of just coming to the forefront when talking about heat-related illnesses. And basically what these are is they protect our body, and it's part of the way that we are able to acclimatize to heat. As humans, we are not very good at acclimatizing ourselves to the cold, but we are able to acclimatize ourselves to the heat over a period of time. And one of the ways that we do this is through these heat shock proteins. Basically, they help prevent damage to the cells, and they help correct any damage that has taken place. So if we do acclimatize to the heat, then the effect can be less on us. So in order to acclimatize, you'll see the military practices this quite well, and hopefully with maybe some insight from an athletic trainer, our football teams and things like that can also do the same. So basically the recommendations are 1 to 2 hours a day of exercise, and it takes about 2 weeks. So hopefully our football teams are looking into this and understanding that, it's best to start out these players that have not been training throughout the summer, and now we're going to start them in the August heat. If we can do that first through just no extra gear, and then, maybe work up towards having the full pads on. And if we start them right away with the full pads, we're going to see a lot more issues with the heat injuries. No benefit to pre-hydration or pre-cooling like you see there on the bottom. We're going to talk about that a little bit more towards the end here. Some of the other topics that we're going to cover in addition to heat stroke tonight are heat exhaustion, heat syncope, heat cramps, and then also exertional hyponatremia. So we'll talk about that here in just a little bit. So what is heat stroke? It is absolutely a life-threatening emergency, and it is one of the few things in medicine that can kill us quite quickly. One of the things that Dr. Casa had said in that conference is that if we can cool these patients within 30 minutes, it's 100% survivable. That's a pretty bold statement to make in medicine. There's not really a lot of things we say is 100%. So it's important for us as EMS providers to recognize this right away and treat it really before we transport. So what we're looking for as far as symptoms is going to be an altered mental status is going to be one of our primary things. So basically, if someone has an altered mental status in heat, consider it heat stroke until proven otherwise. If it ends up that it's a low blood sugar or another issue, then so be it. But we need to treat for the most life-threatening thing first. And it's defined as a core temperature of 104 degrees. And when you're taking temperatures, if you take a temperature, be cautious of the method that you use to do that. Really, a rectal temperature is going to be our best bet pre-hospitally. I know that some of you may also carry a temporal scanner or an oral thermometer, and in the environment, those really don't work well. The only really reliable one is going to be the rectal thermometer. There used to be an old kind of myth of heat stroke patients were not sweating anymore. They had to have that dry red skin, and that's simply not true. If you for example, have a firefighter that's been working a house fire in July, and you take off their bunker gear, you're going to find that they're extremely wet and sweating. The same thing with your runners and participants in your football games or marathons. And same thing, you're going to see that they're still sweating. So they certainly can be sweating and still be in heat stroke. So what are some of the risk factors for this? Obviously, obesity and a lower fitness level are certainly going to be some high risk factors for this. And a lot of times we'll see that highly competitive, that never quit personality. They don't pick up on those early warning signs that their body's giving them, or they ignore them because they're trying to make the finish line or get the good time or impress the coach. And so they don't want to stop even though their body maybe prior was telling them, hey, I've had enough of this. And they just push on to the point where finally they collapse and they have that altered mental state. Diabetics tend to be a little bit more at risk for this, those with cardiac history, and then also certainly a history of previous illnesses. And if any of you have a lot of contact with your athletic directors, The Corey Stringer Institute website has actually a lot of additional material on how to re-enter an athlete into the training and how to bring them back up to full speed effectively without putting them at risk for another injury. So what do we want to do for these patients? We want to cool them first, transport second, and the best way that we can cool them is through cold water immersion, and that's as cold as you can get it. If you have ice water, that would be ideal. At a lot of the organized events, you may find that they will have basically a large Rubbermaid tub full of water, and then they'll also have coolers full of ice, and so then if they need it, they'll dump that ice into the tub, and they'll put the patient right in there. And the reason that we push for this is because you lose heat 25 times faster to water than you do to air of that same temperature. And cold water really is defined as about 68 degrees or less. So if you think of the water that we have here in Michigan, almost all of our water is considered cold water nearly all year round. So while you may not have a tub at an organized event like this, there are ways that we can get access to this water to transport or to treat them before we transport. And you may have to be a little bit creative with it. Fire departments are always a great resource. Obviously, they have a lot of access to water. A lot of times they may be able to set up their drop tank for you. If you can get towards a bathroom with a tub or a shower and get them wet that way, even a lake or a pond would be sufficient if that's the best thing that you have. So like Dr. Costin had said, if we treat this within the first 30 minutes, it's 100% survivable. And once we get beyond that 30 minutes, now we start to have issues with tissue damage, organ damage. Kidneys particularly are affected by this. A lot of times these patients will end up on dialysis. They'll have rhabdo going on. There's a lot of times swelling in the brain, and those cells will start to congeal. So it can really be detrimental to the patient if we don't treat it quickly. And one of the interesting things about this is it's not so much how high your temperature gets, it's how long you stay at that temperature that's the problem. If you look at some of the elite runners on marathons, they will know that at the end of their run, their temperature may be 106, 107 degrees. And so as part of their routine cool down, they'll go to the med tent and they will get into one of these cooling tubs, and they'll basically sit there and talk on their cell phone for a few minutes while they cool themselves, because they know that that's how their body is going to respond after running an event like that. And that's okay, and that's not a big deal for them because they've cooled themselves effectively within that short period of time. So it's really those patients that have that temperature above 104 for greater than 30 minutes that are the ones that are really at risk. So prior to this change in the protocol, we had said that you should put ice packs on the neck, the groin, the axilla, and just move them to a cool environment. And that's completely an inferior cooling method. It's really not going to do the patient any favors at all. Even if you were to put ice packs over the patient's entire body, it would take about 40 minutes for them to lose just 1 degree. Whereas if you put them into cold water, they could lose a degree about every 3 minutes. So it really doesn't take that much extra time to see that they can really drop their core temperature fairly quickly, and then we can transport them to the hospital. If you consider the time that it takes us to get to the patient, do our assessment, if we were to load them up, transport them, take them to the ER, have the ER do their assessment, and then start the cooling process, in nearly all cases we're going to be beyond that 30 minutes, and we're just not going to be doing the patients any favors that way. So why does this work so efficiently? Some of you may have been in on the presentation that was done, I think maybe a month or two ago, by my partner at work on cold-related things. And he had in his presentation that if you were to go into cold water in the winter time, just as a normal thermic individual, that you could last an hour or greater before becoming hypothermic. And what I'm going to tell you in this case is that if you take a heat stroke patient and put them in cold water, they're losing a degree about every 3 minutes. So what's the difference there? Well, it's what controls our heat. And the main thermostat for our body is the hypothalamus, and it's located near the brainstem. So it's always going to get the best of everything. It's always going to be bathed in, warm blood and get all the resources that it needs. Well, the problem in heat stroke is that the hypothalamus is also too warm. So even though we take that heat stroke patient and we put them into the cold water, there's temperature receptors on the skin that say, hey, this is cold, you know, we're okay, we don't need to deal with this anymore. The hypothalamus is going to override that and say, no way, it's still too hot in here. I'm not going to prevent us from losing heat like I would taking a normal thermic individual into cold water. So it's not going to allow us to shiver. It's not going to put forth those protective mechanisms because the hypothalamus is still too warm. So as I mentioned, we lose heat about 25 times faster in water than we do of air of the same temperature, and that's why it's so important to get these patients into cold water as quickly as possible. So even if they are unresponsive, we can still get them in that water and just keep their head above water. We can still do other treatments at that time too. It's okay to, you know, pull an arm out and get an IV started. We can, you know, pull an arm out and get a blood pressure, check pulses, things like that. Those are also doable things even when they're in that water. And our goal then is to cool them to about 102 degrees. If we're not sure, we don't have a rectal thermometer, we don't have a way of checking exactly what their temperature was, about 10 to 15 minutes is a pretty good baseline for how long we would want to leave them in that water. And hopefully in that time we can start to see some improvement in their mental status. So there are some critics of cold water immersion, and one of the things that comes up frequently is when we tell people to put someone in cold water, they say, well, what about cardiac issues? Aren't we going to cause cardiac problems, especially, you know, as our patients get up in years? And there are actually no documented cases of that ever happening. And it's one of those things where really the risk of not cooling them is too great to not do it. So if we know that they have heat stroke, we absolutely have to get them in that water. And that's why I say that an altered mental status in the heat is heat stroke until proven otherwise. Because even if we get them in the tub and we find out that, you know what, it's a blood sugar issue, they have low blood sugar. Well, now we simply just have a wet diabetic, you know, not that big of a deal. But if we wait and we don't cool these patients, it could be fatal. So it's so important for us to get on that right away. Others have said that, well, the patient will shiver, and, you know, because we do have temperature receptors in our skin, and they'll shiver and they'll vasoconstrict and then they'll heat up and they'll actually get warmer. Well, that really doesn't make a lot of sense if you think about it. If that were true, we would all be able to go into like Michigan in January and swim with no problem. And obviously we know that that's not the case. So that doesn't really add up either. Uncomfortable for the patient or the rescuers, well, I think the patient's life is going to be, you know, a priority to our comfort level. And you certainly can continue on with other treatment. Unsanitary conditions, they say that the patient may defecate in the pool that you're cooling them in, and you know, that may happen. But again, if we don't cool them, we have bigger problems, and we possibly have a fatality on our hands. So hopefully that makes sense to you. A couple of record holders here just to illustrate how high people's temperatures can get. 52-year-old male with traditional heat stroke, also helped along by alcohol. He had a core temperature of 115, and that was after 25 minutes of cooling. So I don't even know what his temperature would have been to begin with, but that's unbelievably warm. And he actually survived that. The other one here was a 23-year-old. He was in a motor vehicle accident, and he ingested 100 doses of the meth that he was carrying, and then he fled. He had a core temperature of 113, so unbelievably high temperatures. But again, it's not how high your temperature gets, it's how long you stay at that temperature. That's the big deal. And then as we discussed, you do want to rule out other possibilities, because certainly altered mental status can be caused by a number of things. We're going to check their sugar, make sure there's no head injury, certainly drugs, and then hyponatremia, which we'll talk about more in a little bit here. So moving on to heat cramps, and I think in the coming years you will see less and less of these following topics being listed as heat-related, because we're finding more and more that these really don't have to be a heat environment for them to occur. It can be in cold environments as well. So what are heat cramps? Basically, they're just an acute painful muscle spasm. I know most of us here probably have had them before. Generally the legs, arms, sometimes the abdomen, and I think at time you're going to see them called exercise-associated muscle cramps, because it isn't only the heat that these occur in. So what causes these? Well, we've come up with a lot of theories in the past, and none of them have quite panned out. But what they are finding more recently is that It's more of an issue of fatigue and muscle damage, and that there's also a genetic component to it. It does tend to run in families. So what are heat cramps not? They are not dehydration, and they are not an electrolyte balance. That was kind of the prevailing theories in the past. And they've done a lot of studies on athletes, drawing labs before and after having heat cramps, and there's no sign that they have any dehydration or electrolyte issues. So you see here listed this 2011 study of 210 Ironman triathletes. They did before and after electrolytes, and they looked also at their body weight changes to see if there was a dehydration component, and there was no difference in those that had cramps and those that did not have cramps. And the reason that they're thinking that it's not that as well is because if that were true, then you would think that the entire body would be having an issue, that it would be a systemic problem. But really, we see these cramps occur in the most used and the most worked muscles. So what they're finding now is that those that cramp, for one, they have a family history, but they also set out faster goal times relative to their fitness levels than those that do not cramp. They've also found that they're the athletes that don't taper their workouts prior to the race. They've had more intense workouts in the week leading up to the race than those that do not cramp. So that leads us to believe there's a fatigue component there. And then also when they do labs, they find evidence that there's muscle damage going on. So basically, they find that it's a fatigue and a muscle damage related problem that's causing the cramps, and that it has nothing to do with electrolytes or dehydration. And basically, the best way to prevent this is to prepare appropriately for what it is that you're going to be doing, pace yourself appropriately to what your level of fitness is, and to taper it before your big event. They find that stretching can help, and that's kind of another indication to us that this is a local problem, not a systemic problem. And basically just stopping and resting and taking care of yourself that way. One of the odd things that they've kind of found is that putting salt on the tongue will relieve a cramp in about 40 seconds. Now, 40 seconds obviously is far too quick for salt to get into your body systemically, so it can't be a sodium issue. But basically, it sends a weird link to your brain and your tongue saying that this is a good thing, and it makes those muscles relax. So kind of somewhat of a mystery as to how exactly that works, but certainly not a sodium-related thing. They've been able to prove that in the lab values. So pretty benign, but can be pretty painful and frustrating for the athlete that's dealing with it. Heat syncope is one that we see quite often. We will see this oftentimes with athletes. It'll be at the end of a race. And what we'll find with them is that as they're running, their legs are basically acting as a second pump. So they have their heart going, they have their legs going, and all of that is working to pump that fluid throughout their body. Now, all of a sudden, at the end of the race, they stop and they've lost that second pump. And their body doesn't quite catch up quickly enough, and they end up passing out. They recover very quickly, and that's one of the things to look for to make sure that heat syncope versus something else is these patients recover really quickly once their body kind of realizes, hey, I don't have that second pump anymore. You know, I got to just rely on the heart to do this, and it ends up kind of all leveling itself out. The other time that we'll see this is a lot of times it's the elderly. Maybe they are gardening, they've been kind of down on their knees for a period of time, and then they all of a sudden stand up. Well, while they were on their knees, and if they were in a hotter environment, they were vasodilating, so they were sending that blood to the periphery. It was pooling down towards their legs, and now all of a sudden they stand up and they don't have the compensation to get that blood back up to the brain quickly enough, and it will cause them to pass out. Again, in and of itself, not all that big a deal, but something certainly to be aware of. Heat exhaustion. This is basically, you may have heard the term bonking before. Some athletes will say, oh, I just bonked on that race, or I hit the wall. And what they're really saying that this is simply fatigue in the heat. We used to think that there was a dehydration component to it, and they're really not finding that that's true across the board. So somewhat of a warning sign to the body of, hey, I've had enough of this, and I need you to stop because I can't keep going this way. And so we need to heed those warning signs. there may be a component of fluid loss, but not necessarily. So if the patient does complain of thirst, it would be fine to give them oral fluids. But these patients are going to be awake, they may be subdued, they may be lethargic, but they're going to be able to respond to you fairly appropriately. They're going to have a fairly normal core temperature, so we can rule out that it would be a heat stroke issue, and their vital signs are going to be fairly normal, so you're not going to see significant tachycardia or significant hypotension that would maybe indicate a dehydration issue. It's all going to be pretty normal. So what do we want to do for them? Basically just move them from the environment that they're in into a cooler environment, let them rest. If they're thirsty, they can drink. If they're hungry, maybe they could use a few calories to kind of get their energy back up. But they can recover nicely on their own without any issues. It's actually the most common of the heat-related illnesses that we see. And I think this quote kind of sums it up pretty well. It's the inability to continue exercise in the heat due to cardiovascular insufficiency, basically not enough blood pumped to the heart, and there's energy depletion. We used to think that these were all kind of on a sliding scale, that heat cramps, may lead to heat exhaustion, which may lead to heat stroke. And we found that that's not necessarily the case. Just because you have heat exhaustion doesn't really mean that you're going to end up with heat stroke. They're kind of separate entities in that way. And the last thing that we're going to talk about is exertional hyponatremia. And this is something that we see fairly often in our longer races. Here locally in Grand Rapids, we just had our 5th third riverbank run last week. And basically, this water intoxication is one way of describing this. There's two things that need to happen. First of all, the patient has to overdrink. And there also has to be some sort of biological abnormality going on where they have this antidiuretic hormone, which we all have, but that they have an excess of it, causing them to hold that fluid and not pee out the excess that like they normally would. And we've seen a number of cases of this at Riverbank, and one of the problems is there's watering stations at nearly every mile, if not every couple of miles. So for years, we were telling our athletes that you had to pre-hydrate and that you had to drink as much as you could tolerate. Our athletes abided by that, and that's really where we started to see these issues. So normal sodium is 135 to 145, and it's one of the most tightly controlled things in our body. Just a little bit too low, a little bit too high, and we really see some pretty significant problems. So sports drinks kind of are one of the things that led to us having this. And you can look at like Camelback's previous slogan. It was hydrate or die was their slogan. So we really push for our athletes to drink as much as possible. And really what we should be telling them is to simply drink to thirst. If you're not thirsty, then you are fine and you don't really need to drink. And for some reason, we seem to disregard the thirst mechanism in our bodies. We listen to everything else pretty closely, but we seem to find that that's a faulty one, and that's really not true. Just because we're hungry doesn't mean that we're malnourished, but yet if we're thirsty, some of us have come to believe that that means that you're already dehydrated, and really that's not true. It's just that you're thirsty and you should take something to drink. But it takes a lot more than that to become dehydrated. So it really happens actually fairly often. They looked at a 2002 Boston Marathon, 488 runners. 13% of them had a sodium level of less than 135, and then 0.6% had less than 120, which is a critical level. They found that it's more common in women, and there's a few reasons that they think that. One is they feel that women tend to follow the rules a little bit more, so when they've been told drink as much as possible, they feel that women try to actually do that a little bit more than men do. And the other thing is they feel that they have generally smaller body sizes, body mass, and that they're drinking more compared to their body mass. And they've also found that women who are menstruating are at an additional risk for that. And basically the estrogen and the progesterone work on the sodium-potassium pump and actually cause the cells to release more sodium into the body that then gets excreted and lowering their sodium levels. So we talked a little bit about the sports drinks. Back in 1965, is when Gatorade came around. The University of Florida Gators football team was looking for something to increase the performance of their football players, and that was how we came along with Gatorade. And they basically said that if you drink this, it has all the electrolytes and everything that you need in it. You won't have these issues with cramping, and you won't have these issues with hyponatremia. And that is simply not true. All the sports drinks in the world, you cannot prevent hyponatremia by drinking a sports drink rather than drinking just straight out water. In order for the fluid to have enough sodium in it to prevent you from having heat stroke, it would basically have to be the salinity of salt water, which nobody's really going to tolerate or want to drink. So what do we see in these patients? They look a lot like they are intoxicated, kind of like the name water intoxication. They're going to have that unsteady gait. Initially, they may notice feeling a lot of fluid sloshing around in their gut. They can't keep up on their normal pace. They're going to notice some swelling as they're retaining all of that fluid. So a wetting band might be tighter, or any sort of jewelry that they have on. They may begin to vomit up some of the water that they've been holding on to. And then as we get further into it, they're going to end up being confused. One of the patients I dealt with on Riverbank last year, I believe it was, I came to him and he was sitting on the side of the racetrack, and he tried to tell me that he was dehydrated. And I said, well, why do you think that? And he said, well, I'm a physician and I just know that I'm dehydrated. And he said, okay, well, how many of the watering stations did you stop at? And he said, well, I stopped at all of them. I said, okay, well, you're not dehydrated then, but, he didn't want any medical attention really. So, well, let's try to stand you up. We'll see how that goes. So we attempted to stand him, myself and another person. We were on either side of him. And he said, okay, I'm standing, I'm fine. And in reality, he was at about a 45-degree angle, and we were holding him up. He really had no ability to stand on his own, but he felt that he was. Another patient that we had last year was a similar situation. He also stopped at all of the watering stations, and we found him laying on the side of the racetrack, and he asked us if he was still running. I said, no, sir, you are not still running. You're laying on the ground, definitely not running anymore. But very confused, and they can end up going into having seizures and becoming unconscious, and can end up being fatal. So one of the things that our runners and our athletes always worry about is the dehydration component. So they've looked at all the runners and marathons and things like that, and they just don't find that that's the truth. If you look at the elite runners, you will find that the ones that actually win the race are the ones that are technically having the most fluid loss, and they also have the highest core temperature. On a day-to-day basis, most adults have actually about 4 pounds of extra fluid that we're just carrying around in us. And so there's really no need, even on a marathon level, to have any fluid during that time to stop at any of the watering stations. It's okay not to urinate during a race. If you urinate during one of those races, you're probably drinking more than you really need to because your body's getting rid of it. So the number one sign really of dehydration is going to be thirst. We're talking an intense thirst, a thirst that is, I will do absolutely anything to get water, no matter what it is. My only priority in life right now is to get water. That's dehydration. I think dehydration is one of the far overdiagnosed things in medicine. We tend to just kind of throw dehydration out to just about anybody, and really it takes quite a bit of effort to become dehydration, particularly for those that are otherwise healthy. So how do we treat this? Basically, we first need to have the patient stop drinking. No more fluid. And the other thing that has to happen is their brain then has to stop that ADH production, that antidiuretic hormone production. And once they start to have a significant amount of urine output, then we're going to see some improvements in them. So in a pre-hospital setting, if we were to really aggressively treat it, we would start by giving 3% saline, so a hypertonic solution, which most of us probably are not carrying. So we really do need to have these patients transported. Also because we don't, in most cases, have a way to measure exactly what their sodium levels are unless you're carrying an iStat, which most of us are not. So in the hospital, they are going to, via IV, give that hypertonic saline, that 3% saline, they're going to give about 1 to 2 milliliters per kilogram per hour. So it's going to take some time, and eventually this patient will do quite fine, but they do need to be closely monitored at the hospital. There was also a competition a few years back, probably a number of years ago now, in Chicago, where there was a radio contest. They asked all of these brides to win a wedding dress, and all they had to do was place their hand on a car, and they had to drink a certain amount of water every hour, and they had to not urinate. And the last one to have their hand still in the car without leaving to go to the bathroom and having drank the requirements that they had set forth for them would win this wedding dress. And what happened was the winner actually ended up dying of hyponatremia. She had basically drank so much water that she had flushed all the sodium out of her system, and she died of hyponatremia. And the radio station ended up being sued later. But it's pretty dangerous. We really need to just stress to our patients to just simply drink to thirst. In my wilderness and remote teaching, we talk to a lot of people that do camp counselors and lead groups, and there's a lot of groups out there that still have minimum requirements of the amount of fluid that their participants need to take in, and that's kind of a dangerous, slippery slope to be on. We really just need to stress that drink to thirst. I'm hoping this video will work for you guys. I don't know if you can maybe let me know, but this is a video by Dr. Tim Noakes, and he is the leading expert on hydration, and this is just a quick little interview with him. Emma, is that working okay?
I can hear it on my end. Hey, Michelle.
Yeah.
Apparently I was just receiving some feedback during this video. It looks like the quality isn't great on some people's end.
Okay. All right, that's all right. It's pretty much done anyway, so we can stop it here. So, yeah, I don't know how much you were able to catch of that, but basically it was just a quick interview with Dr. Tim Noakes and basically reinforcing the point of drink to thirst.
And Michelle, I don't know if there's a way you could maybe send that in an email to me and I could send it out to all the participants. That's also another
Sure,
option.
I will try to do that. Yeah, I'll try to do that.
Thank you.
Okay, and that's really the end of it. So I think if you're okay, we can open it up with some questions if there's any.
Okay, everybody. At this time, I will go ahead and unmute all lines. If anybody has any questions or comments for Michelle at this time, please speak up.
She kind of answers.
Does anybody have any questions for Michelle at this time?
No.
Michelle, do you have any questions?
I do not.
Are there any comments from any participants that are on the line right now? Again, I just want to reiterate that, I thank everybody for participating in tonight's webinar. And I just wanted to let everybody know again that you have 2 weeks, or by Monday, June 6th, to complete the evaluation, attendance form, and quiz. I will be emailing that out to all of you prior to this webinar. I will also have this webinar, the recording up on the website, on Michigan Center for Rural Health's website, so please look for that in the next couple days. It does look like maybe there's a chat, so let's see. Oh, it looks like you have gotten some good feedback so far from Michelle. In the chat box, it says that it was a very good presentation.
Good.
So just a reminder, everybody, please look out for my email afterwards. And again, if Michelle can send me the video that she was trying to show everybody, I will send that out to you as well. And thank you again, Michelle. That was a phenomenal webinar. And I just want to let everybody know that there will be no webinars for the summer. I may have one lined up for the end of August, but if not, please look out for a September webinar. And again, there will be no summer webinars. And again, thank you for your participation in tonight's heat-related injuries webinar. And you will have 2 weeks to receive your 1 credit of continuing education if you fill out all 3 forms. Thank you, everybody, and have a great night.
I had to hit for the camera. Oh, there we go.
Thank you, Michelle.
Yep, thank you.
Bye.
Have a good night, everybody.